Thank you, Heather. Kia ora, everyone, and good afternoon. Don't forget to raise your paddle because I've got a lot of slides, so I don't want to go over time. So I'm just basically here to talk about the NZPrEP study and where we're up to at the moment. So the NZPrEP study is a demonstration project of HIV pre-exposure prophylaxis in Aotearoa, New Zealand. Now, is this going to work? Wrong way around. Have I got it the wrong way? Right, so I won't go over this because the previous two speakers have talked about it really, but basically there were a couple of key studies that were done in 2015 that in the UK and in France that demonstrated that PrEP is effective at preventing HIV acquisition in gay and bisexual men at higher risk of HIV. And since then, other countries like Australia and the UK, Australia's leading the field in this and initiating population rollout of PrEP, and the UK is also, I'm not sure where they're at, they hadn't quite started when I was over there in June, but they're anticipating that they'll have at least 10,000 people on PrEP over the next 3 years. So in contrast to New Zealand, there has been a decline in HIV diagnoses in the UK, despite increased testing, and in New South Wales there's also been a drop in HIV notifications. So it would appear that HIV prevention strategies are working in countries that have robust prevention programs. So basically NZPrEP started as a discussion between our service and other interested parties in the sector as how to set up and run our own demonstration project in New Zealand. And so we're working with NGOs like NZAF, Body Positive, the University of Auckland. We've got some very supportive community pharmacists, and of course we've got fabulous financial support from Gilead Sciences, and ADHB is providing some support for the study. So Auckland's a good setting for this. Approximately 6.5% of gay and bisexual men in Auckland are HIV positive, and over half of new HIV infections are reported in Auckland. We've got 4 regional clinics, so we cover 3 DHBs, so there should be good access available for most men in Auckland. That's just one of my daughters, they're very keen show jumpers. Had to get that in there. So basically the first hurdle was to get the money. ADHB turned our application down for the research, but Gilead fortunately agreed to pay for the medication and also provided an extra $150,000 for some of the research associated costs. ADHB is paying for the laboratory testing that's not part of the research, so that's the HIV, syphilis, STI testing, the clinician time. And NZAF has agreed to $30,000 of additional funding. We don't have any funding yet for the planned qualitative research, and the behavioural research is from a separate funding stream. We wanted that to be independent from the medical side of things. So the next hurdle was basically getting ethics approval, so we got that at the end of 2016. Around through the middle of the process, Truvada was approved as HIV PrEP, and the ADHB Research Office granted approval as well. So the protocol is basically based on the New South Wales Prelude Protocol. It's an open label, single arm treatment evaluation study. We've got aiming to recruit 150 participants, and it's basically gay and bisexual men who have sex with men who are at increased risk of getting HIV, so recruited, basically identified during routine clinic visits, websites, targeted promotion and community partnerships. The study's going on for a duration of 24 months. Unfortunately, we were limited to 150 participants because of operational requirements of our service. We've had some funding cuts, and we've lost a couple of specialists this year. So the aims basically is to look at the practical implementation of PrEP in a New Zealand sexual health setting, and to look at the feasibility and to look at clinical protocols to make sure we optimise our service delivery. And we're interested in looking at adherence, uptake, how long people stay on it and are retained in the study, and we're also looking at how it affects risk behaviours, including sexual partnering, condom use, and looking at STI and HIV incidents. And there's also some analysis of behavioural and qualitative measures. So the eligibility, basically, it's basically you've got to be living in Auckland, aged over 18 and able to attend regularly for follow-up to partake in all the required study procedures, and you have to be able to be contactable and have reasonable proficiency in English to be able to complete the online behavioural surveys. I won't talk about the ethnicity quotas because Peter's going to mention that. And basically they have to be at ongoing risk, high risk, and receptive condomless anal sex is the risk factor that we're really looking for, and there are some other risk factors such as a recent diagnosis of a rectal bacterial STI or syphilis, or use of recreational drugs such as methamphetamine. So basically people can ring the 0800 number where they speak to a nurse in response to advertising or some of the other initiatives that are going on to advise people about the study, or they may be someone who's just coming for a checkup and the person thinks, well, yes, this person looks like they should be on PrEP. So basically sexual history is taken to make sure they fit the behavioural criteria and that there aren't any health contraindications to going on PrEP. They had a routine screen, HIV, syphilis testing, screening for hepatitis, multi-site gonorrhea and chlamydia testing, and we do some testing of renal and liver function tests to make sure that they're not at risk of getting any complications from the medication. The person is given some information to take away about PrEP and a consent form, and they can have a look at that before their next visit, where basically if they are diagnosed with HIV, they go into, obviously linked into routine care and treatment. If they're negative, they see the research nurse and a peer educator. The nurse goes through their results and any STIs are treated, and they're offered any immunisations that they may be eligible for. They also see a peer educator that's been provided by Body Positive who gives some risk reduction intervention, and they're supplied with condoms. So if they're happy with all the study procedures and they sign the consent form and they're given a prescription of Truvada, and they sent a link to the online behavioural survey. So basically they just basically come back 3 monthly for follow-up until they decide to exit the study or the study finishes, and at each follow-up visit they get routine STI testing. We repeat the serology for HIV and syphilis and check their renal and liver function test, and they're reminded that they'll get a link for the survey. Okay, so just before we were ready to start, we found out that we didn't actually have an institutional contract with ADHB and Gilead, so there was a bit of an anxious waiting for that to be approved. But our community pharmacists were very supportive and agreed to provide medication until they could be reimbursed when the study medication was shipped. And that was finally happened at the end of April, but we did start enrolling people before that. So just some early results. We've got 124 enrolled so far. There's quite a wide age range. The mean age is 32. Just under half of the sample are aged under 30. We've got quite good participation by Māori and Asian. Our Pacific participation's a bit lower, and there's some, it's quite interesting hearing about why that might be. Apparently some of the feedback is that a lot of the people in the Pacific community see themselves as low risk. They're using condoms and they don't think PrEP's needed. There's been some good response rate to the behavioural surveys. I'll let Peter talk about that. So just some STI data, about 23% of people had a baseline STI. The most common was rectal chlamydia, but we did diagnose 2 people with syphilis, and that compares with the STI prevalence in the PROUD and IPIGAY studies. And since it's early days yet, but so far we've had some follow-ups, and about 25% of people have been diagnosed with an incident STI. And again, predominantly rectal chlamydia, but we've had 2 cases of syphilis and no HIV seroconversions, which is good. People also seem to be reporting very high adherence to their medication. That's just the STI data showing what we've found at baseline and follow-up. Nearly done. And also we found that this has been a really good opportunity to do some health interventions. So 17 participants have been commenced on HPV vaccination, 36 have started hepatitis A vaccinations, and 21 have commenced hepatitis B vaccinations. So there's some other health benefits from being involved in the study. And so far we've had 6 people who've exited the study, and mostly because some people have felt that they were no longer really at risk or it wasn't for them. One person had severe diarrhoea, which is probably not related to the medication, but didn't want to come in to have an assessment, so we don't really know what was going on with him. And one person, there's only been one person that we've had to advise to stop because he had some abnormal liver function tests and they went quite high, so we advised him that he should stop. So issues so far, how many? We've got 1 minute. Basically, we had to refine the behavioural criteria early on because we didn't feel we were getting people that really were that high risk, so we added in the stipulation that they'd have to have at least 5 contacts in the last 3 months. They didn't have to have a condomless anal sex with all of them, but they had to have a minimum number of contacts. Managing the ethnicity quotas is needing some sensitivity to manage that. People who are not eligible are generally quite accepting, and there's been some interesting discussions around them. Some of them are very low risk, and those that are mainly topping and using condoms, we do offer them the option of going to a GP that prescribes generic PrEP, and they've been very positive about that, saying it's affordable for a lot of them. The bookings are going to be quite challenging as we get more people coming back for follow-up because we don't have a lot, we've got a reduction in clinical staff, and so we're going to need to expand to nurse follow-up as we've already got some pressure, and we'll need to formulate some protocols to manage that. And we're finding a lot of abnormal LFTs, most of which are inconsequential, which is what you'd expect when you start screening well people. And I think that's it. That's just one of the problems I thought we'd mention is happening in Auckland. And I'll be interesting to see what happens in the next couple of years. But yeah, we're worried about the high STI rates already. And that's the people that are involved on the steering group. Okay.
Thank you very much, Sunita. As I said, we've got